Good morning, ladies and gentlemen. Welcome to Kinfon Dermatology Classroom. I would like to take this opportunity to go through the preview of childhood histiocytosis. We know that cutaneous histiocytosis is not belong to one single disease, but is an umbrella term that includes many dermatoses with many names and many phases of presentation. And some of these names include the histiocytosis X, Langerhans cell histiocytosis, eosinophilic granuloma, lateral Silvi, Hand-Scholler Christian, Hashimoto-Prisco, Rossi-Dorfman, multicentric reticular histiocytosis, juvenile xanthogranuloma, benign cephalic histiocytosis, etc. and etc. Today I'm going to focus on childhood histiocytosis, which are the Langerhans cell histiocytosis, and non-Langerhans cell histiocytosis include the juvenile xanthogranuloma and benign cephalic histiocytosis. As far as Langerhans cell histiocytosis is concerned, we need to have a high index of suspicions before you would go for a biopsy to confirm the diagnosis. And there are 4 practical steps that I would like to share today. I would like to start with high and broad index of suspicions. As you look at these 9 images, they look very different, but all represent different morphological presentation of Langerhans cell histiocytosis. The most common manifestation for Langerhans cell histiocytosis, or the most well-known one, is the patient presented with persistent seborrheic dermatitis like eruption over the scalp, over the eyebrows area. The main clue is that they are not responsive to the usual treatment. At the same time, they are having hemorrhagic papules and as well as the blood papules lesions over the seborrheic area. Another common manifestation is persistent nappy rash that not responsive to your barrier cream, steroid, and antifungal. At the same time, there are multiple purpuric papules and nodules over this area. Please proceed to take a biopsy to confirm the diagnosis of Langerhans cell histiocytosis. The less common or less well-known manifestation include those patients with skin color or hypopigmented molluscum condensatum-like lesions. Another one would be the ulcerated dermal nodules, and this particular manifestation is common among the newborn babies with congenital reticular histiocytosis. The least common manifestation or morphological presentation in my practice over the last 18 years is vesicular bullous that rupture, become an ulcer, and recover with miliar formations. So once you suspect a case, proceed for biopsy. The classical description of Langerhans cell is coffee bean nucleus as well as abundant eosinophilic cytoplasm. To confirm it, you need a panel of immunohistochemical stain with positive CD1A, positive Langerhans stain, positive S100, and negative CD68 are the characteristic description in terms of the special stain for Langerhans cells. But bear in mind, Langerhans cell is a normal cells that could be stained in the epidermis. So the clue to diagnosis is the pattern of infiltrates. In Langerhans cell histiocytosis, there are clusters of Langerhans cell over the upper dermis with variable degree of edema and also eosinophilic infiltrations. Over time, the Langerhans cell will migrate up to the epidermis and cause breakage of the epidermis and manifest as ulcerated nodules with variable degree of edema. So this is a patient with special stain, CD1A, that stain the membranes, and there are clusters of Langerhans cell with eosinophil and dermal edema over the upper dermis here. And these are the abundant eosinophilic eosinophilic cytoplasma surrounding the bean-shaped nucleus. So if you have interest to know a bit more, please go to www.pediatricdermatology.com.my.